I have really, really wonderful relationships with my patients. I meet them oftentimes when we're in a really hard spot. And then many times we get to a really good place. They come in and I see them, I hear about their Christmas and I hear about their 2026 plans and I hear about their grandkids and all the things that they've been doing. And that's really, really wonderful.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg and my guest is Dr. Laura Chambers. Laura specializes in gynecologic cancers. She is a surgeon and also a principal investigator here at the James. Today we'll talk about cervical cancer, the risks and symptoms, prevention, and some of the advances in treatment, including immunotherapy. Laura will also fill us in on her research, which includes looking at all the misinformation that's out there about cervical cancer and also the role of microbiomes in the stomach and how they can impact treatment. Welcome to the podcast.
Thank you. I'm so happy to be here.
We're happy to have you and to talk about cervical cancer, it's a very important topic, and women, we're going to fill them in on everything they need to know. So first, sort of talk about what causes cervical cancer.
So cervical cancer, I think first we'll just start by talking about what is the cervix.
Yes, yes.
And so the cervix is the lowest part of the uterus that connects the uterus to the vagina. And so many people think of, the cervix and the uterus together, but they actually can have totally different types of cancer. So the most common cause of cervical cancer is HPV. So HPV is the human papillomavirus, which is a very common virus within the population, but it accounts for over 90% or even more than that of cervical cancer cases. And it's not just HPV exposure, but it's persistent HPV. So what I mean by that is most people that are exposed to HPV will clear that virus on their own as a result of their body's own immune system. But for people that have ongoing virus or ongoing viral infection, those are people that are the highest risk. So, one of the biggest things is to prevent prevent infection. And the best way to do that is through HPV vaccination. So the current vaccination that we use is the Gardasil vaccine that contains protection against 9 leading strains. So it protects against 7 cancer-causing strains and then 2 wart-causing strains, and has over 95% effectiveness at decreasing cervical cancer and HPV infection. And that can be given as early as age 9.
And I know there's some confusion about the ages, and so fill us in on the ages, and is it a one-time thing? And if you're older,
Yeah.
I think they've changed the ages. So this could be some of that misinformation that's out there. So you're going to give us the right information.
Yeah. So approved from 9 to 45. The age recently expanded in recent years. For children, it's 2 doses of vaccine, and for older people, it's 3 doses. That's at one time. You first get the vaccine, then 1 month later, and then 6 months later, and then can go now up until age 45. I think one of the things that we know that the vaccine works best before people are ever exposed, but we also know that in people that have been exposed to HPV, or even people that have been tested positive for HPV, there's now some research that supports that HPV may decrease the risk of cervical dysplasia in the future, which is a precancer. So there's been some really exciting research in people that have known precancers and then undergoing surgery that it can decrease the risk of that coming back in the future. But it's definitely one of the most important things that we can do to decrease the risk of not only cervical cancer, but other HPV-associated cancers too.
So what would be the symptoms of someone who has this in the early stages?
Yeah. So for many people, they have no symptoms. It's picked up when they come in for their annual well woman visits and they get a pelvic exam with a pap smear and HPV testing. So that would be, many people are asymptomatic and have no issues. But for people that do, things that can be pain, abnormal bleeding, especially bleeding after intercourse. We call that postcoital bleeding, abnormal discharge, people that have more larger disease or larger tumors, they may have pelvic pain, pelvic pressure, back pain, So I think, one of the biggest things is going in and getting your checks and getting your screening done. But if you have abnormal bleeding or abnormal cycles or new bleeding that's not, that's outside of what your periods used to be, really getting that checked out is super important.
So at what age should women or even teenage girls start with these kind of women wellness checks?
So it's honestly, we don't really have the right answer as far as when to do that. I mean, I think that it's really important when people are growing up and talking about their like menstrual cycles and things like that. Generally people should bleed once a month for somewhere between 4 to 7 days, and it should never be heavy. It should never be soaking through pads an hour. That's usually what we say. Every body is going to be different, but I think having some awareness of what your normal cycles are like is really important. And a lot of that probably is going to start with, a pediatrician or primary care doctor starting in the home and things like that. For pap smear, so pap smears and HPV testing, that is how we screen for cervical cancer. So a screening test is designed to pick up a cancer or precancer at an early stage. And in average risk populations, then we recommend starting cervical cancer screening at age 21. So that would be definitely like when people should go in the first time. But obviously, if people have periods that are abnormal before that and things like that, it's definitely important to seek care sooner.
So good. So if you start a yearly test at age 21 and you have the HPV test and the pap smear, then knock on wood, the odds are really high that if you were to get cervical cancer, it would be caught in the really early stages.
Yeah, so the way over the last couple of years, the way that we screen for cervical cancer and pre-invasive disease or cervical dysplasia is pre-invasive cervical cancer. So it's basically abnormal changes before it becomes cancerous. The way that we screen has really changed over the last couple of years. So our current guidelines are we start doing pap smears at age 21. And when people first start, when they're 21 to 24, we just do pap smears alone every 3 years. The reason for that is we know within that age group, many people will be exposed to HPV, that the chances of people clearing the HPV on their own is very high. So in people that are younger, we do just pap smears. And so a pap smear is basically a speculum exam where we take a sample of the cells from the outside of the cervix and it's looked at in the lab. After people, so that's 21 through 24, and then when people are 25, then the recommendation is to start something called co-testing, where we do both a pap smear, which is looking at the cells, and then also checking HPV as well. So we do 2 parts to the test. The reason that we do 2 parts is HPV testing has been shown to be a lot more sensitive at picking up precancers. And there's 2 types of HPV, number 16 and number 18, that are actually the most associated with risk. And then as people go through their lifespan, there's various different intervals between how often we should screen. And if you're having the smear alone or the HPV testing together. And there's a lot, it's very complicated actually. But in average age people, between when they're 25 to 30, then we do pap smear with HPV. And then after that, it's co-testing as well. But in the last couple of years, actually just in the last 2 years, there's been a lot of push towards just HPV only testing. And there was actually an FDA approved home HPV test where it's called the teal wand. And basically people can do a self-collect of HPV at home and then mail it in. And then from there, it's triaged to if they're good or if they need to seek care from a doctor.
Oh, that's interesting, because as you were talking about that, I was thinking that some women, and I know that like in Appalachia, don't have access to physicians to do this. And the James has an outreach program that there just aren't. A lot of women just don't have access in that. And if they don't get checked, they could be in trouble.
Totally. I mean, one of the biggest things with cervical cancer is it's really a disease of people that are underscreened and in underserved communities. And one of the things and not only just physical access to care, but there's a lot of other barriers that people have. If you have, you work a lot and you have little children, it's really hard to get in and get screening. For many people, with a history of trauma or, a lot of other issues, related to that, like getting in and having a speculum exam is painful and invasive and stressful. So being able to do a self-collect swab at home and then mail that in and not have to have that is a really amazing thing. So it's really new, but I think that there's hopefully in the years to come going to be a lot more that we can do to like improve access and for screening.
Okay. So despite all the screening and prevention and vaccines, some women get it and come here because this is the place to come. In Ohio, you are part of a team of world-class surgeons and oncologists. So where are we at with treatment? And I know immunotherapy, I believe, is becoming a bigger part of that.
Yeah. So the way that cervical cancer is treated really depends upon the stage of their cervical cancer, and stage for any cancer means where it's spread to. So it's probably helpful if I just talk you through. So like if I see a patient in my office, so most of the people that come to my office will have had a biopsy done somewhere else, and they're found to have cervical cancer in the biopsy. So one of the biggest things is, when I meet someone, I talk to them about the diagnosis of cancer, and then we talk through how there's a lot of options, and they can range from a hysterectomy, and that can be a simple hysterectomy or a radical hysterectomy. If there's cancer spread outside of the cervix, then we consider radiation with chemotherapy. If there's spread to lymph nodes, we consider radiation with chemo and immunotherapy. And then if there's spread to other organs, we do chemo and immunotherapy. So there's a wide variety of options. When I meet someone that has, cervical cancer that's spread outside of their uterus, it's actually a really hard conversation because many people, they feel like, well, if my cancer's in my cervix, why can't my cancer just be removed? And that's really hard to understand, but we know that the cervix is so close to the bladder and it's so close to the bowel that when we have spread, there's not really a way to do that radical hysterectomy anymore without it causing some issue with the bowel and the bladder. So that's why the radiation is really organ preserving for those important structures.
Okay.
So that's the radiation. And then we also have research that shows that in people that have node positive disease, there's benefit to adding immunotherapy to their radiation treatment.
Node positive, it traveled through the lymph node somewhere else?
Exactly. So that's something that we are very frequently using in people that are candidates. And then if we meet somebody that unfortunately has stage 4B disease where they have spread to, say, the liver or the lungs, then we do a combination of chemotherapy with immunotherapy and then potentially with another medicine that blocks cancer cells from making blood vessels called bevacizumab. So we have a tremendous different number of options for people. And that's why when we first meet somebody, we're doing that exam, we're talking to them about what we think we see that first day, but really letting them know we need to get more testing to get the right plan in place. So
my sense is that because the James is so well known and so good that people who've been diagnosed and even treated elsewhere, when the treatment's not going good or when it's diagnosed in a later stage, another hospital will send them here. So you perhaps see a lot of people with the later stages of cervical cancer.
I think so for sure. And I will also say, there within the state of Ohio, just in general, like we do see a significant number of people that, live in rural communities that didn't have access to screening, didn't have access to vaccination. So we do see a significant number of people diagnosed with advanced disease, especially young patients as well. And many times those people are, maybe have been gone into another hospital with bleeding or pain, and then they're found to have cancer that way. And so normally then they're transferred to the Janes into a hospital, and we work on their diagnosis and get them set up that way. But you asked about immunotherapy, and I think I just want to touch on that a little bit more. So, when we're thinking about cancer treatment, radiation is these beams of energy that go through the skin and kill the cancer cells that way. And they work by just damaging the cell's DNA so they can't replicate. Chemotherapy is usually given as an infusion, and it goes through the whole body and works on all cells that are dividing. And what immunotherapy does, it's really, really unique, is it's an infusion the same as chemo, but it's an antibody that goes into our body and basically helps our immune system find the cancer to kill it. So we know that one of the ways that many cancers can grow in our bodies is they can hide from our immune system. So within our blood, we have these cells that are constantly circulating around, and they're looking for foreign things to attack and clear. And cancer cells are smart, and they basically have these ways that they can put proteins or things on themselves that they can hide and they can't be detected. So what immunotherapy does is it basically helps our body. It kind of blocks that hiding response that cancers can do and allows our immune cells to say, hey, that's not right. We need to kill that cell. And immunotherapy works really well for many types of cancers, especially cervical cancer. And the combination, adding chemotherapy with immunotherapy, we know that there's some benefit to doing both, because when the cancer cells die with the chemo, it helps the immune system then learn what a dead cancer cell looks like and helps it go after it.
If they ever come back.
Yeah, exactly. And so immunotherapy is very different than chemo. Chemo has, the usual side effects you hear, the nausea, the vomiting, the low white blood cell counts, things that we can manage incredibly well, and we're very good at doing that. Immunotherapy, because it activates the immune system, it can cause a lot of off-target effects, including, activation of immune cells in other parts of the body. So sometimes it can cause inflammation of the lungs called pneumonitis, inflammation of the bowel, colitis with diarrhea. So it's one of those things we just have to spend a lot of time with patients talking about, like, these are all the things that may happen, and just, need to contact your care team if you're having any unusual side effects.
Okay, that was a great overview. And we're going to take a quick break. And when we come back, we're going to talk about some of your amazing research.
Cool.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with Laura Chambers, and you wanted to mention before we talked about your research the difference between a speculum exam and the pap smear.
For sure. So this is one of the things that I see is a really common, it's very commonly that people get confused. So, when someone comes in for a gynecologic exam, we do, as part of a pelvic exam, we use what we call a speculum, which is this instrument that helps us look in the vagina and visualize the cervix. And a speculum exam is part of a gynecologic exam that can be done for pap smears or STD screening. And I think one of the things that I have seen is that many people will think if they had a speculum exam, whether that was done for discharge or whether it was done in the emergency room for bleeding, that speculum exam automatically means they had a pap smear for cervical cancer screening. And so I think that's one of the things to just know, is that just because you may have had a gynecologic exam, that does not necessarily mean that you've had the appropriate cervical cancer screening.
So perhaps a woman should ask, say, what did that include?
Exactly,
a pap smear?
For sure. Yeah,
Okay.
did that exam include a pap smear? When is my next pap smear due? That's super important.
Okay. Now, let's switch gears to research. And I'm always fascinated by physicians, surgeons, researchers. That's a lot on your plate, and you somehow manage to do a lot of research. But one of the areas, and as being a former newspaper reporter, I'm very curious about misinformation out there on social media about cervical cancer and related subjects. So what have you found? What misinformation is out there, and how can we correct that?
Yeah, so my interest in this field really sort of has grown over the last couple of years, and in part because when I'm in clinic and I'm talking to people about their diagnoses and the treatments, people have said to me, well, I saw this on TikTok or I saw this on Instagram. So it really inspired a lot of curiosity in me to think, well, what are they reading on these sites? Like, what are they seeing? So we've done a couple of different studies, but one of the ones in particular was we took the leading 500 posts on TikTok about GYN cancers. So we took the top 500 posts, we broke them down by disease site. So looked at cervical cancer, ovarian cancer, endometrial cancer, vulvar cancer, and then something called GTN, which is a condition of cancer sometimes involving the placenta. And basically what we did was we took these cancers and we looked at the content of the post. So who was posting it? What were they posting about? If it was an educational post, if it was a patient post. In the post by patients, we looked at when they were posting. Was it at the time of diagnosis? Was it after? Was it about their symptoms? And we looked at the values of things that they were reporting. Specifically for when we looked at the top 500 posts on TikTok, we found that about a quarter of them were about education specifically. So the intent of the post was to educate a listener. And then we applied this, it's called a discern score. So it uses 5 criteria to grade how good the information in the post is. So how accurate, what sources are they using? Is it biased? And in these studies, we've typically used 3 investigators that have all graded the post, and then
they listen to it and grade it.
Yeah.
Okay.
So we identify the post, and then we have separate investigators that grade it using this scale, and then we check that it's all concordant at the end. And this discern score uses a scale of 1 through 5, with 5 being really high quality information, and then 1 being very poor quality information. And we found that essentially the average score was about 1.5. So
that's not good.
Very poor quality. Yeah. So I think, there's a number of takeaways from these studies, and we've done several more, and we have others in process. I think when it comes to the misinformation piece, I think there is an awful lot of misinformation about cancer treatments out there on social media. And I think that, we really just have, I think as clinicians and providers, we really just have to, talk to patients about what they're reading, where they're getting that information, be open to the questions that may come from these, these non-traditional sources of information. I think I often have patients come to me with I saw this on Instagram, or I saw this on social media. And if I just write that off, that's, don't worry about that, I'm going to lose trust, right? Because they're interested in that. So I think you really just have to take the time to talk it through. But I will say it's not all bad. Social media, has really become in looking at a lot of these posts and seeing what's out there, people are posting a lot of really valuable things about their diagnosis, what symptoms they may have had, sharing experiences about their chemotherapy, talking about things that really matter to patients, like losing their hair, managing their fatigue. Many women that have gynecologic cancers, they may have loss of fertility, a new menopause. So I think what I've really seen is within these communities of people that are posting, there's a lot of good. There's so much good. And I still, I take care of a number of people that are younger that may not know anyone else with cancer, you know, or they may have a rare disease that no one else really has, that they're getting unconventional treatment, or they don't have anyone to go to. So I actually tell my patients, I'm you can go on social media, you can, put your disease as a hashtag and see what's out there. But I think it's really important to take it with a grain of salt and always talk about it with your medical team.
And from what you're saying, it sounds like if you want to hear from women going through what you're going through and how they dealt with it, that's a great way to use social media. But if you want information about your actual disease and the science of it, you should, in addition to listening to this podcast, you should go on a website. Like yesterday, in preparation for this, I looked on the James website for cervical cancer and the American Cancer Society and the National NCI. I mean, you don't look on, just some random person's TikTok or website to get information. You go to a guaranteed expert.
For sure. And I think it also, times are changing. The way that we consume information and media is changing. And I think as providers, we have to meet people where they are.
That's good advice. And the microbiome has become a topic more and more in the news for a lot of different things. And probiotics have become a big industry. So what have you found in terms of gynecologic cancers?
Yeah. So I'm going to take it even a couple of steps back. So, One of the things when I'm in clinic and I'm talking to someone about, their new cancer diagnosis and we're going through options, surgery, chemo, radiation, all the things we talked about at the beginning, I find that most people look at me and they say, what else? Like, what else can I do?
Diet,
exercise,
herbal
stress,
treatments,
herbal treatments, supplements,
Yeah.
like that comes up really commonly. And one of the things that I found was that there's not a lot in the what else space. There's not a lot of high quality evidence. There's not a lot of good science. And that's probably why we go back to TikTok where people are putting all these things on it. I mean, I think it's all related. Like, people want things outside of just chemo and radiation.
Yeah, they're
and things
scared
like that.
and they want
They want to do
something. Yeah.
Exactly. So really over the last 20 years, there's been a lot of knowledge about the microbiome. So every part of our body has different microbiomes. They're basically collections of millions of billions of bacteria that live within and upon all of our body's surfaces, our skin, our mouth, our gut, everywhere. And before I went to medical school, actually, I did a master's, and my master's was focused on the gut health and how that influenced the development of metabolic syndrome, obesity, and how exercise impacted that. So it's something that has been, like, I've always been very interested in, like, feeling as good as you can and wellness and exercise and things like that. So I did this master's and then obviously put it aside to do medical school residency fellowship. And then during my fellowship, I did a year of research in a lab. And during that time, we kind of reignited this research in gut health, and we looked at the role of the gut microbiome in ovarian cancer. During this time, we did some studies where we evaluated the effect of the microbiome on treatment for ovarian cancer. And we found that in the setting of an altered microbiome, so where the gut had been changed, the response to chemotherapy was decreased. And, then that led to some other studies that we'd done. One of the things that really, there's a lot of, we don't really understand exactly why the microbiome influences response to cancer treatment. But in many cancers, melanoma, lung cancer, colorectal cancer, GYN cancers, we've started to understand that the gut influences the immune system, and it does that through producing some metabolites and some hormones and things like that. And the gut's really active in this space. So one of the things that we've done here, a couple of different things. So we are in that prior research that I did, we looked at changes to the microbiome and how it influenced response. And now we have started a clinical trial where we're going to give patients with ovarian cancer probiotics. So this is a randomized trial where patients getting platinum chemo are going to get a probiotic or a placebo product, so that we won't know what they're getting. And we're doing this in collaboration with Pendulum. Probiotics are an amazing probiotic company that have this 5-strain probiotic product that has some anti-inflammatory bacteria in it. We're really excited. So that will launch here at the James soon. And then we've also done some studies looking at the role of dietary fiber in cervical cancer as well, and basically showing that in the setting of a high fiber diet, a very high fiber diet, there's an increased response to immunotherapy.
Wow, we've covered a lot. Thank you. And you're very motivated. That's obvious. You go above and beyond for your patients and your research. So what does motivate you to do all this?
When I was in medical school, I found myself very drawn to taking care of women. I find that women tend to be the people that take care of everybody else in their life. And especially most patients with gynecologic cancers, they tend to be older. Many of them are mothers. There's just a lot of people that they're always worrying about, and I think I really, really enjoy being a caregiver for them.
Caregiver for the caregivers.
For the care, exactly. One of the things that's really unique about being a GYN oncologist is we meet people when they're first diagnosed. We do surgery. We will give the chemo ourselves. At our division, we don't send out to medical oncology. We do all of the chemo ourselves. And then when people are cured and in remission, then we follow them usually for 5 years, but oftentimes for the rest of their life. So I have really, really wonderful relationships with my patients. I meet them oftentimes when we're in a really hard spot. And then many times we get to a really good place. They come in and I see them, I hear about their Christmas and I hear about their 2026 plans and I hear about their grandkids and all the things that they've been doing. And that's really, really wonderful, And I think that for, obviously not every patient I care for has such a great outcome, but I think even in the patients where we meet and there's a tough diagnosis or a tough cancer, there's usually something we can do, whether it's chemo or surgery or just ways to make people feel better. So for me, it really comes down to the patients and just giving them things that can improve their life, the quality and the length of their life. So
that's a great goal.
Yep.
All right. Well, thank you.
Yep. Thank you for having me.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.